Good morning, everyone. Pleasure to be here. Great to be here with my friend Dilpreet. Can you all hear me okay, especially in the back? I heard some other sessions, there was issues. Okay, good. And I can always talk louder. Dilpreet and I are going to go through, hopefully in about 30 minutes, a handful of slides, share with you some ideas from our respective kind of areas, and then our hope is really to leave a fair amount of time for any Q&A at the end here. So I think we'll dive right into it. Just a little bit more about myself. I'm kind of wearing two hats up here. Interim Chief Managed Care Officer at Bon Secours Mercy Health, where I've had the pleasure of working with those good folks for the last couple of years. Also have my own consulting firm that works with a number of health systems, providers across the country. I come from the dark side, so I'm a 30-year payer guy. Blue Cross, United, most recently ran the West Coast for Centene. About 3 years ago, left Centene, was enjoying my riding out my severance and non-compete in sunny Southern California, and got a phone call from a former colleague that said, hey, can you help out a health system with a difficult negotiation? And I said, no. It's not what I do. I'm the guy on the other side of the table. And they kept prodding me and said, no, that's what they need, somebody that kind of knows the secret handshake and the code and come in. And there is no secret handshake. But I said, okay, I'll come in and help out. And, it was an amazing experience for me. Got to work with some amazing folks, kind of, again, be on the side of the angels for the first time in 30 years in my healthcare career. And we had at the end of the day, after a long, testy negotiation, we had a pretty positive outcome. And next thing you know, my client was handing out my business card, phone ringing, and I woke up with half a dozen clients across the country and said, I'm not going back to the dark side. There's a lot of fun. And since then, I've been having my own consulting firm. And so just a quick idea here, some footprint. But enough of the shameless plug about me. What I want to do today is just share some thoughts, some ideas. Depending on your organization, you might hear some of these and say, that doesn't work for us, and it probably doesn't. But hopefully you'll hear a few things, a couple of nuggets that you can take back, and the next time you're locking horns with Aetna, Cigna, United, whoever, maybe some of these will be helpful. So. Wherever I go, whoever I talk to, I've spoken to groups like this multiple times, actually presenting in a month at AHA's annual meeting in Nashville. The story is always the same. If you're a small provider group, it's like getting the payers to even return your phone calls and engage with you often feels impossible. Some of them have you apply through a link, for God's sakes. For the hospitals, you can probably get them to return your phone call, but taking you seriously and working with you is a challenge. It's the rare situation where someone says, yeah, we're happy with the payers, they treat us fairly, and we have a good partnership. And if you have that, that's fantastic. Definitely the exception, but it's just become more and more difficult. The relationships are strained. You've had consolidation in the payer industry, where now most of you deal with, if not all of the big national for-profits, certainly a number of them, and they're just tough. They're tough in how they approach it. They're going to push you and test your resolve. The story is usually the same from providers: downcoding, denials, bad debt, fair reimbursements, just are all super challenging. So I think it goes without saying, I think most of you're not alone. I think everybody, really struggles with how do we deal with these payers, and, attempts to have relationships and partnerships and others always end up often, one-sided. Again, no absolutes here. So, what I want to share with you is just a framework to think about. Again, doesn't apply to everyone, but there's pieces of this that, will absolutely apply to you. And, a couple things I would say. One is you have more leverage than you realize. You have more leverage than you realize. From a payer perspective, at the end of the day, we sell networks, we sell access. No network, no product. And trust me, I've been burned where I got too tough with some health systems in the past and got basically kicked out of communities because they want out a network, and our customers, employers, seniors in particular, right, don't change doctors. At the end of the day, your patients are more loyal to you than they are the logo on the ID card. That's sometimes hard to think, like, really? It feels like the payers have all the leverage, and of course they have leverage, but providers have more leverage than they realize. The second part is have a strategy. Have a strategy. Most providers I work with tend to view managed care contracting as a necessary evil. Can't wait to get it over with. Oh man, that Cigna renewal's coming up. Whew, geez, let's get it done. And it tends to be approached from more of a transactional standpoint, which again really deleverages you at the negotiating table. And so think about a strategy on how you approach it. So broad framework I would encourage you to, and I work with my clients on, is pretty simple. Start early, build a strategy. With that strategy, get alignment early with your leadership team. One way to ensure failure is, somebody forgot to get the CEO on board or the board on board. Things start to get public, they start to get tough. There's articles in the newspaper, members are calling, and now somebody says, what the heck are we doing here? Whose dumb idea was this? And the whole thing will collapse. And at the negotiating table now, you just have to kind of surrender. Start early getting alignment. Don't wait till the end. Up front, talk about the strategy. And that really leads into the next part with building a case off of the data. And Dilpreet will talk more about the data. I'm not a data company. I don't sell anybody data. You got to have the data. If you don't have the data, you're just taking a swag at it. You're making up numbers. Believe me, payers know that in a heartbeat when somebody's just making up numbers and, we need a 12% increase. Why? I don't know. You got to have the data. Once you have that data, it does a couple things. It allows you to understand what everybody else is getting paid, right? You're able to really look at where are we in the market? Are we getting average pay? Are we getting above average pay? That information really helps to anchor internally. Yeah, we want to use it at the negotiating table, but most importantly, it really helps for folks to get aligned and to say, you know what, we are not being reimbursed appropriately. We need to have a different outcome in this negotiation. And I'll talk a little bit more about the data. The contract language, often equally as important, sometimes overlooked, but looking at the language. Now, are you going to be able to rewrite United's entire contract? No, of course not. But think strategically about a small list of must-haves that are deal breakers. That shouldn't be a long list, right? Don't go to your rev cycle company and say, hey, give me everything you want to change about United. You'll never get it, never get a deal done. But one or two things that are deal breakers for you. Do you need material change language, ready rate language? And then have a longer list of, hey, we'd like to have this, maybe a third list of nice to have. They're good throwaways sometimes in negotiation. You're not going to get everything, but if you can hone in on one or two, often, especially again, hospitals, more leverage, you can often be successful. And then, of course, the negotiating part of it. As you get into the negotiations, you'll probably quickly learn that you're really not talking to the real decision maker. The real decision makers are the P&L owners at these health plans. And so, I would encourage you have to start with the frontline folks, but you want to have a strategy ultimately for talking to the executive leadership at Blue Cross, at United. Are you going to talk to Steve Hemsley? No. But you can talk to some of the market CEOs and other folks at United, local Blue plans. Certainly you can engage, often higher level leadership. Again, easier for the larger health systems to engage those folks than some of the smaller provider groups. But your best deals are going to come from those folks that understand the broader dynamic of what it would mean if you were potentially out of network. And then ultimately, really understand your leverage. What are your leverage points? How do you use it? How do you, create a dynamic at the negotiating table where the payers feel like, I better step up here, or I'm in jeopardy of, losing this network, and they understand really what that network means, and I'll share a little bit more about that. My old colleagues hate when I say this, but the reality is, payers don't negotiate in good faith. They just don't. So you go and get the data, you show them the data, you're paying everybody else 15% more, that's not right. Does that mean they open up their checkbook? No, they just don't. They just don't. And so the truth is they use leverage, and so should you. And the question really is kind of what leverage do you have? How do you create leverage regardless of who you are in the negotiations? And so, I won't go through every bullet here. I don't think I can read them all from this distance, but, just understanding that, number one, patients are more loyal to you, understanding how do you get to higher level folks ultimately at the 11th hour negotiations. Government programs, right? This is an interesting business wherein the earnings horse for the payers are government programs. That's where they make all their money. Medicare Advantage, Medicaid's a very lucrative business. Health exchange, incredible margins when I was in my last shop. Commercial business, often not as much. Most of it's self-funded. Yeah, you make a good margin, but on like a $90 admin fee. Reverse for providers, right? It's government business, it's the worst payer, and commercial, that's the best. And so thinking about that, thinking about, how loyal seniors are to you and to their doctors. Seniors don't change doctors. They just don't. So thinking about timing, thinking about how you leverage, public opinion. One piece maybe I don't have in here, just for the interest of time, is again, not true in all situations, but certainly for larger organizations, don't enter a negotiation without a hard end. What do I mean by a hard end to the contract? A termination. Right? Don't bother. If you don't have a termination on the table, the payer's strategy, really simple. Start late, slow roll, run the clock out. Next thing you know, it's December 31st. Oh man, geez, sorry. Oh, okay, well, what are we going to do? I mean, what are you going to do? You're going to hang a sign on the door tomorrow? Sorry, closed? No. You kind of have to take their last offer. And so, but when you think about termination, think about it differently. Think about it like a renewal notice, right? Or a non-renewal notice. Setting a hard date that says, hey, we're going to come to agreement on a new contract by this date. Or mutual assured destruction. And that's the point. With a term on the table, it creates accountability for them as well to come to agreement. And I think the slides are available. There's ways you can deleverage yourself. Try not to do them. Don't argue with payers about their profits. They love that. They know how to argue that. No big deal. Don't break up your organization. Negotiate everything at once if you can. Don't negotiate hospitals today, physicians tomorrow, one state or one facility. It just deleverages you in the process. So a lot of tidbits on here. I won't hit them all, but I've talked about just anchoring on the facts and the data. Really important. Be consistent with that. Be consistent in your message by starting early, having a strategy, stick to your script, stick to your message. Remember, you're all on the side of the angels. You're just there to save lives, deliver babies, take care of people. Payers never, ever can win in a public fight. You just can't. I had a lot of public fights in my career, and I lost all of them. It was just, I'd go to the food store, and oh my God, there's somebody from an employer, and what's going on between you and the University of Rochester, and you can't, to try and convince them that somehow they're overpaid or they're inefficient. It's, not given what we're doing as a payer and the money we're making, you can never win it. Escalate it quickly. It's really important with the frontline negotiators. Try and get to know quickly. Try and get to know where when that frontline negotiator, that VP, Director of Negotiations, Director of Network, says to you, I can't do anything more, thank them. Thank you. You can't do anything more for me, so I got to talk to your boss, or your boss's boss. Thank you very much. And go above their head. Payers, I kind of still leave this in there. At the end of the day, payers really do kind of know two things, pain and leverage. And so, if your strategy is to be partners with payers or be friendly or want to be nice, this is not about, blowing things up. It's not scorched earth. You want to be professional, take the high road all the time, but just know that generally payers define positive relationships in ones where they really have the upper hand, and generally you're extremely underpaid. So, I think I'll leave it and turn it over to Dilpreet, but, have a strategy. Just think through your approach and how you do it. Evaluate and assess your contracting team. Most providers, hospitals I work with in particular, their contracting team, great people, technically some of the smartest people I've ever worked with. But again, more in a transactional mode, not in a broad strategic mode. You can't be at war with everyone at once, right? You can't take on everybody at once, or at some point the community is going to say, wait a minute, who's the bad guy here? So be strategic, whether it's the calendar, hey, we got a big negotiation coming up with Aetna, or you look at, who's our biggest payer or who has the worst rates with us. You can't tackle everybody at once. You don't have the bandwidth. You'll burn everybody out. So it's going to take some time to get there. Just remember, you've got more leverage. Know how to use it through the process. Is this going to guarantee, triple, 10% increases? No. But you know what? Instead of a 3-year deal at 2.5, 2.5, 2.5, if you can walk away with 5, 5, and 5, you know what? That adds up over time. It makes a big difference. So it's incremental wins that are real and big dollars and reposition you. And number 3 is just a shameless plug.
Well, Scott just walked you through a pretty in-depth roadmap for running the negotiation itself. Just to maybe start off with a quick background on myself, I'm Dilpreet, the CEO and co-founder here at Trek Health. We are the data backdrop supporting managed care teams and finance teams across the country as we walk into these negotiations. We support roughly 150 provider organizations and health systems across the country as that proposal is getting generated and as we're setting our internal metrics that we want to target, understanding the market backdrop. This is really backed by regulatory change. Everybody's heard of maybe the pricing transparency initiatives that have gone on over the past few years. Most relevant to us here as provider organizations would be the hospital price transparency ruling that requires us now to publish the MRFs on our hospital sites. There are 2 other components of the transparency and coverage ruling that are important to know about. The first is there's a payer component. The second is there's a drug component. The payer component is today live. So when we consider the hospital and the payer sources of data, we've got roughly 7,000 endpoints across the country, including every commercial payer and every hospital that has to publish data, giving us a broad set view of all in-network allowed amounts across the country. And really, this is the first time in the history of America where I can point to a specific NPI number, whether a facility or a provider, and identify a specific service and give us a dollar amount that the payer is reporting. We've maybe worked with claims data sets before, and I'll talk a little bit about what's different with this data versus claims in a moment. Important to know, however, that although payers are required to publish data, it's deeply gamified. There's roughly 300 terabytes of data that's getting published across these payers on a monthly cadence, and that's more data than the sort of congressional libraries combined, roughly 10x that's getting published on a monthly cycle, and it would be impossible for any single organization to go out and get a deep set view and actually analyze that data at the level of each service line if we didn't run through a pretty significant data engineering challenge behind the scenes to deduplicate it and identify the insights versus the noise. And that's what Trek Health does. We take these 300 terabytes of data and distill it down to roughly the 70 terabytes of insights. The data has now been published for a little over 2 years on the payer side, and so we take that data on a quarterly cadence and pull it into our system to support our partners. We pride ourselves in really focusing on being the provider-centric organization. There are other pricing transparency companies that are working on this problem. To my knowledge, we're the only organization that exclusively works with provider organizations to support this exact use case. We do not support payers or pharma, life sciences, et cetera. What exactly our solution does here is two primary things. The first is we know that providers are leaving significant leverage on the table. In many cases, 3 to 7% of revenue that might be on the table depending on historic benchmarks that we might not have a market purview into is what Trek Health can allow you to go out and see. Most of the organizations that we talked to before, and you all would have your own perspectives here, typically might be using Medicare-based benchmarking or your internal RCM metrics to understand where you stand within your respective payers. Now you can actually benchmark your rates to the commercial market averages. You can compare yourself to the specific health system across the street, the specific provider organization across the street, and build out a robust strategy taking that into account. Also, legacy analytics are typically siloed and generally have a lag. I mean, with any aggregated claims data set that you might have worked with before as you're building out your strategy, that's typically processed through a clearinghouse, might be 6 months or 9 months delayed, and give you a tiny market snapshot, maybe of a specific area, but not a full world view. The payer by law now has to publish every in-network provider for every service. And so just to give you a little bit of an example of the types of organizations that we work with, we also support Bon Secours Mercy Health behind the scenes as we jump into negotiations, as well as organizations across the country. Here's just some examples of the types of outcomes that we've started to see with our provider organizations. We might expect maybe a 3 to 5% rate hike, but as we've identified distinct, let's call it arbitrage opportunities or real entrepreneurial opportunities to go out and benchmark ourselves to market and redo our fee schedules from the bottoms up. We've seen just some examples here, 15% rate hikes with Cigna, 10% rate hike with, I think it was United Healthcare and a bunch of others. I want to spend a moment talking specifically about why pricing transparency data versus claims data sets. I talked a little bit about that earlier, but I think there's one primary point from this slide that I'm gonna draw on here. Every contract, of course, is bound to confidentiality. If you were to walk into a payer negotiation prior to this pricing transparency data going public with a claims data set, that would get stricken out by legal teams. It's not actually something that you can use. We're now taking public data. This is not something that's bound to confidentiality. It doesn't need to get stricken out. You can actually use this as a real data point as you go into the negotiation. As Scott mentioned, we often find that the primary point at which it becomes most useful is as we're setting our internal benchmarks and our internal targets, although you can actually use this as a specific talking point in that negotiation itself, and it won't get pushed out by the payer. I want to also highlight one limitation of the data as it stands today. It's inclusive of all commercial data sets, so that would include all ACA marketplace plans as well as all employer plans. What it yet does not include is managed Medicaid and managed Medicare plans. That's in the roadmap, and CMS and HHS have clarified that that's likely to come. You might have also all heard about regulatory changes over the past few months. There were new executive orders that are going to lead to drug data sets that will be public soon, following the full PBM chain from the drug manufacturer down to the pharmacy, being able to understand how that pricing is going through the healthcare system as well. Here's some real-life examples that we drew from the pricing transparency data, just to give you a sense of what we actually see within the underlying data. In this particular example, we've taken each zip code group in the state of Texas for, in this case, specifically DRG 470, the hip and knee joint replacement inpatient code, and we just took the top percentile, the 95th percentile in each market. What you'll notice is that by geography, by zip code group, roughly 350% variance in reimbursement, in this case from BCBS Texas, for each zip code group, just depending on where you are. And this, in many cases, the zip code groupings are relatively arbitrary grouping. In some cases, you can have a single metropolitan area. There's no clear divide as we look at the variance between urban and rural centers. It's generally an outcome of which market has which specific provider entity and how much leverage have they had and how much have they actually pushed on negotiations. Well, I also want to showcase a specific capability that we have here. Actually go back to one slide. Now that we're sitting on years of data, Trek Health can actually support you in understanding what exactly have my competitors locked in as successful rate hikes. We're sitting on longitudinal data for years. That's going to continue to grow every quarter and every month as we go forward here. And so some of our clients have come to us and said, look, we know that the competitor across the street just negotiated with the Regional Blues or United Healthcare or whatever it might be, and we can take your service lines of interest and actually show you specifically what the outcome of their negotiation has been as this data is live and changing on an ongoing basis. In this particular example, on the right side of the screen, you can see the average change for Aetna in the state of Texas by DRG service. And on the left side, you can actually see a zoomed in example, in this case for Baylor, locking in, I think it's a 3.8% rate hike for a particular service that we can track as an outcome of how our data is structured. So not only can this give you a dollar-to-dollar analysis as to how I'm doing in comparison to the market, but it can give you the longitudinal view. So even if we're at the top of the market or we're maybe at the average, what will that look like 5 years from now? What would that look like 10 years from now? And are we actually set up to win the market and to be in the market long term based on this trajectory as well? As Scott mentioned, of course, there's a deep negotiation process that you all are working through as you run this process with the payers directly. I see pricing transparency data actually enriching each step of that process. From prepping your data, we now can not only take your internal data sets, but enrich that with this external powerful data set so that you are more aligned in getting your stakeholders internally on what that target should be. And as we go through contract modeling, identifying scenarios, figuring out what we're actually willing to accept, we can now go into these conversations with a market view in mind rather than a myopic internal perspective related to ourselves or maybe to governmental reimbursement. Finally, for Trek Health specifically, as I mentioned, provider-centric, we have really focused on building out a series of views around this exact negotiation. We've got two different ways that we can slice the data, top-down or bottoms-up. We have executive-level dashboards that allow you to see how you stand in comparison to market averages by service line and by payer, or if you want to do the flip and you want to do a deep research on a specific set of services that you want to enter into, we've got those bottoms-up views as well. What I'll leave us with here is that as we think about pricing transparency going forward, there's primarily 3 or 4 primary use cases that we see in the market today. We've talked mostly about contract negotiations today. That's really the primary area we see health systems capturing value with pricing transparency data. The next is service line expansion. We often find that you already have contractually obligated rates for areas that you might not have facilities, you might not have providers today. We can help you model that out based on true market averages and true rates today. Third would be acquisitions. We often see that as providers are considering expanding into net new service areas and they want to go out and strategically acquire specific practices based on their existing reimbursement standing, whether they're top of market or average or below, we can help you have that view prior to you jumping into these acquisitions and even identifying those specific practices you'd like to go after and acquire. We've got roughly 20 minutes left in the session here. We wanted to keep time for a Q&A for any questions that you might have here, and so I'll pause here. We've got our contact information for myself and Scott as a follow-up on this slide. There's a few things that we don't have. First would be utilization information. I don't know the volume of each service being rendered. The second is exactly what you just mentioned. We don't have that administrative overhead that should be considered when we look at the raw dollar amount. The dollar amounts that are being posted are the allowed amounts, inclusive of the patient responsibility and the insurance reimbursement for each particular service. And also just to call out, one other limitation in the data is there might be underlying contractual terms that should be considered, whether that's a DRG carve-out, whether that's a stop loss, something else. We would not have that perspective. We would just have the contractually obligated allowed amount. Typically how we deal with that is by separating that out into the overhang that we should consider in the modeling itself. Maybe we want to discount our allowed amount by the 15% denial rate that we're dealing with as we go into negotiation. That would be the next step.
Yeah, maybe just one quick thing to add to that. You can probably assume payers are equal opportunity abusers. Everybody's getting the same payment integrity edits, all of that stuff generally applied pretty much across the board. But yeah, really understanding that's important, right? Medicare Advantage, on average, most folks are yielding, 85 to 90 cents on the dollar. And so being able to have the internal analytics to identify yield as well as rate and bring that to the table's another important factor. You're not going to get them to turn off all their switches. You're not going to get them to not do care management, but you bring it into negotiations because at the end of the day, it's real impact on revenue.
Super tough, guys. Joe DeMont, CFO with Keyword Pueblo Health. I have two questions for you, Dilpreet. One is, do you accompany the client organization in the face-to-face negotiations for the higher rates? Okay? The second is, does the payer want to kill you after you share the data? And then the third question, how do you get that payer that they're paying other people? Is that through the hospital transparency act? Thanks.
Totally. So Track Health today does not actually accompany the provider in the negotiation itself. That's why we have partners like Scott that we take in to our partners wherever needed. We're the software layer that behind the scenes is powering those insights to create the proposals. We're not actually doing the negotiation yet. And yes, payers are not too thrilled that we're in the market today supporting providers, although there's nothing that they can do about it. This is one of the few bipartisan things that everybody sort of agrees on, is that pricing transparency is good for consumers, good for providers, good for even payers if it's done right. And then finally, what was the third question? Sorry.
Was it how do you get the data?
Yep. So how do we get the payer transparency data for specific other entities? And so, yeah, it's important to note that the hospital data sets are very different than the payer data sets in two primary ways. The hospital data set, each file is specifically tied to one facility at a time. The payer files are the full market view. So the United Healthcare files will have every in-network provider across the board for whatever state or whatever region we're ingesting data. Also important to note that the payer files are not limited to the top 500 services or whatever it is in the hospital sets, which are typically just inpatient services. The hospital files are limited to that, but the payer files contain all outpatient services as well. Anesthesia, DME services, ASCs, everything that you might care about as you consider expanding into professional line items. We've got that in the payer files as well, of course.
Hi, this is a question for Scott. With regard to maximizing yield to contract, how can providers impact benefit design since tied up with health plans can really impact that?
Short answer is you can't. Let me say that. I think it's sort of a default, right? If you've got your own health plan, that's a different story. If you've got some very broad risk arrangements where you represent the majority of a membership in a region, maybe you can. But when it comes to benefit designs, payers are really going to look at the market, they're going to look at the competition. It's going to be difficult for you to do. Bad debt is a big issue, right? Look at a lot of plans today. I mean, the deductibles, the MOOPs, the co-insurance, it's just, for a lot of clients in Medicare Advantage, they're collecting half of the patient responsibility, half, which is pretty shocking. But it's really difficult. It's going to be difficult to influence that, frankly.
Thank you so much. Scott, question. How do you impact as managed Medicare negotiations if that data is not available?
Yeah, so, MA is a whole talk track that we probably talk for hours about, certainly Medicare Advantage. Or as I've sort of like to say, Medicare disadvantage, because there's no advantage to providers for Medicare Advantage. I think a couple things. Again, really hard to impact the down coding, the denials. A few things I'd say. One, I'm not a rev cycle person, but don't ever really write anything off. Full credit to Clint Haley. If you know Clint is sort of the godfather of hospital contracting at Tenet. But Clint, shared with me that he never starts a negotiation without a good old AR lawsuit. So one is don't just let that stuff go just because a payer says it wasn't a 99215, it was a 99212 or something. Bring that up in your negotiations. you can try and collect some of it back. Medicare Advantage, you know, the payers are crying poor. If you look at payer margins, the last couple of years, it's been tough. But, you know, when payers say it's tough, it means they made $3 billion, not $4. I think the only success I'm seeing with anybody in Medicare Advantage is strategically pick your partners. You know, if you don't need to participate with every single Medicare Advantage plan out there. And so, you know, think about embarking down a path, a 2-3 year strategy to identify who are the best partners and maybe participate with 2 or 3 of them. If you do it thoughtfully, strategically, you engage your patients, you do it, you know, during annual enrollment period where they can switch. Again, seniors are loyal to their doctors, not to the logo on the insurance card, and they'll move with you. Yeah, Medicare Advantage is a tough one for providers, and most are, you know, struggling to get 90 cents on the dollar. But even if you run the yields within your payers, you'll probably see a pretty wide margin from some maybe in the mid-90s, some, you know, as low as 80. Boy, just chop off those bottom ones. There was something just earlier this week in Becker's about another 20-something health systems dropping Medicare Advantage plans. I'm not personally, I think dropping Medicare Advantage altogether, going Scripps, I don't know if anybody's here from Scripps, but, you know, they dropped it all together. That's pretty tough because for a lot of seniors, depending on where you're at, you know, Med Sup is too expensive. They can't afford $300 a month. It's not that Medicare Advantage is a great bargain either after they, you know, go to the hospital or see doctors and their co-insurance and things. But yeah, I would say pick your partners, hopefully work with them to maybe get some bad debt offset. Some of the payers will help you on bad debt. Maybe that can tie back into benefit design, that if they have to just start paying for it, maybe they'll realize that, you know, giving Aunt Tilly a $9,000 out of pocket is just not realistic. But.
Other questions? Okay, thank you. We can give our speakers a
Thank you all. Thank you.